vascular problem and inflammatory problem, because the white cells are also involved, the platelets, the vascular, the vessel lining. It's a really a systemic disease. So just another little part of the overview here. There are different types of sickle cell disease, and it's important to know what genotype your patient has so that you'll know what to expect from their phenotype. So the most common type is the SS type sickle cell, where someone's got the sickle hemoglobin in each parent. That's also known as sickle cell anemia. And those patients you have mostly sickle and can have a more severe course. The second most common type is the SC type sickle cell, where someone's got the sickle from one parent, C from the other. That's usually a more mild, moderate course. And on there, if you were to do electrophoresis, they'd have about 55% sickle, about 45% C hemoglobin. And then the next most common types are the sickle thalassemias. There's the sickle beta plus thalassemia and the sickle beta 0 thalassemia. Patients with this, and those patients, about 10% of patients have the sickle thalassemias. About the patients with the sickle beta plus thalassemia, they make a little bit of normal hemoglobin, so kind of a more mild course in general. Whereas the patients with the sickle beta 0, they make 0 normal hemoglobin, so they tend to be more severe and kind of get lumped into behaving like the SS patients do. Again, it's important to know what type of sickle cell your patient has. So that's why whenever we write in the medical record, we write like HBSS or HBSC. We try not to write SCD, because if you write, is that sickle cell disease? Is that the SC type sickle cell disease? So we're trying to write the hemoglobin type that they have. And then from these genotypes, you expect certain lab changes depending on what genotype they have. So the patients, and noted here in red, those are the more severe types, usually the SS and sickle beta 0 thalassemia types. And they're the ones who tend to be more anemic and have higher retic counts because of their chronic hemolysis. Whereas the patients with the sickle, the fourth and fifth columns here, sickle beta plus thalassemia and SCs tend to be more mild, moderate, not anemic at all, or just mildly anemic, and therefore their retics are relatively lower because they don't have as much ongoing chronic severe hemolysis. And then this is the last column, there's the normal ranges. Now, remember, a lot of these patients are going to be microcytic, so the patients with anything with thalassemia, they're going to have a low MCV, so don't give them iron unnecessarily unless you prove iron deficiency. Patients with SC also can have a lower MCV. And then about a third of our patients with SS, remember sickle cell, that's all a beta problem. About a third of our patients with SS have also inherited alpha thalassemia trait and have a low MCV for that reason. So if you see a low MCV, it may just be it may not be iron deficiency. Don't give them iron unless you prove that they're low. All right, so now we're just going to talk about some selected problems that are in the hospital. Number one problem, all patients, all types of sickle cell, is that painful vaso-occlusive crisis. And so it's where the kind of little, the smaller vessels, so where the capillary is going to the venule, you have microvascular occlusion there from the sickle cells. Then I said to you, it's not just about the sickle cells, it's also you have the white cells that are in there sticking to the red cells, to the endothelium. You have platelets that are in that mix sticking to everything, and then the endothelium is just very inflamed. So it's a so it's not just simply the red cells getting clogged up in the tiny vessels. There's a whole lot of problems going on. But most common problem, and teenagers are admitted more than young children are, as y'all may have seen in your experience. And this is some older data, but it's median length of hospital stay is about 4 days, and it's an expensive disease. And that was back in 2006, and that's just the most recent data I had. Yeah.
What's mean stay at our hospital?
I don't know, actually. I don't know. It's been difficult for me sometimes to get data from the hospital, but now maybe with Epic, because Epic's going to fix everything, I can get it more easily. We can have some more data. Unfortunately, there's no test to rule in or out vaso-occlusive crisis. Now, as an aside, y'all may have seen we have this handful of patients who have more chronic pain right now, it seems, and you've noticed us getting a SED rate on them. But there is some data that that a SED rate should, and a white count CRP, those will rise a few days into an acute crisis. But you cannot go by your lab values unless for some of our, don't take this home with you though, and to take this as a, do not do this. Do not use a SED rate as a marker for a pain crisis. However, we are using that for some of our chronic pain patients to aid us in taking care of them, okay? But there's really no test, but you do expect some inflammatory markers to go up. And then it's important to know if ask the patient, yes, well, is this your typical pain crisis or not? Because a lot of these, especially teenagers, they know what typical acute pain feels like. And if it's not typical, think about, is there an osteomyelitis? Maybe they have a little pet turtle at home that they got from the flea market, because at the flea market, they'll sell you the tank, because turtles are illegal to sell, baby ones are. But if you buy at the flea market, you can get the tank, and they give you a complimentary little pet turtle to go with, So that's how you get around getting the baby turtles in South Carolina. So anyhow, so think about osteomyelitis. Could it be, is there some trauma? Do they have another inflammatory condition like juvenile arthritis? We have a couple patients who also have arthritis along with their sickle cell disease. And then other, sickling problems. Are they having splenic hepatic sequestration? Is there gallstones when they're coming with their abdominal pain? Is that mimicking a pain crisis? Do they have avascular necrosis? We have patients who come in with lots of times low back pain, hip pain too, and it can be referred down to the knee. So is there an underlying avascular necrosis going on? But because there's no test, always we're taught to believe the patient. So where are these pain crises? You may have noticed that pain crises are they're different locations based on the patient's age. And so we talked about this yesterday. Whenever everybody's born, your marrow is most active distally in your hands and your feet. As you become older, by the time you're about 25 years old or so, your marrow is more active centrally for all of us. And however, in people who have a sickle cell or other blood disorders who keep an active marrow, the marrow may stay active everywhere throughout their lives. But in babies, they get dactylitis because that's where the marrow is most active. So babies, when they get pain, it's in their dactyls. So you can see, due to necrosis of the bone marrow, and then the surrounding cortex of the bone becomes affected. Whenever these patients are older, as the marrow becomes more active centrally, the pain shifts from the dactyls inward. But they still have a lot of pain, especially in their legs. This was this picture over here on the right, looking at some old bone scan, bone marrow data, looking at where the pain crises were. So in the bones, it's most commonly in the leg, and then in the joints, most commonly in the knee. And that's because there's still some active marrow in those areas, but less in the hands. Now, what triggers pain? And so you often hear patients say, oh, the cold weather triggers it. Well, there's actually a little bit of data to support that. So in Canada, they looked at, this is over here on the right, this is some data from a study in Canada looking at ED visits for pain crises. And they, sorry, just making sure, sorry, excuse me, just a second. Okay. Sorry, we have a patient going to surgery right now. I just have to let Dr. Camps know. Okay. So in the solid line, that's temperature. And so bottom's 32 degrees, high is 77 degrees. And the dotted line are the pain crises coming to the ED. You can see when the temperature goes up, pain crises go down. When the temperature goes down, pain crises go up. So there is some correlation there. So there's some validity to why. And whenever you're cold, you vasoconstrict. And so if you have vasoconstriction in these small vessels, which is where the sickling's already happening, you delay that transit time of the red cell even further, more sickling and pain. Other triggers for pain, infection. So you often hear us asking, have you had a recent cold or any viral illness? Dehydration, that's what you hear us asking about that as a risk factor. Stress, physical or emotional. Menstrual cycles. There's a group in Florida that was looking into this because we see more pain. We see it's not written about in the literature yet, but a spike up seems like in kind of adolescents when they're peripubertal and just pubertal. And then in some girls who have periods, they tend to have some of their periods actually trigger pain crises. So we have many of our patients that are on Depo-Provera to try to suppress, or other means to try to suppress menses if they were a trigger for pain. And then you hear us asking about snoring a lot, and looking for nocturnal hypoxemia, because that can be associated with more pain crises. And here, about almost 40% of our children with sickle cell have sleep study proven sleep apnea, and some of those with hypoxia. So you can and take their tonsils out, treat sleep apnea. That may see a significant decrease in their pain afterwards. All right, so how do we assess pain? Well, a baby can't tell you, I have a pain scale of 8 out of 10. So you look at how their behavior and see what the parents are telling you. And remember, though, some babies, they're going to be crying, but some of them can just become like this first, because just kind of withdrawn and quiet, and because they're even whenever they're in pain, so they may not be overtly crying. For kind of preschool, school age children, we use that basis scale. So I'll pull up on my phone, or we have like a little chart that we can carry around and ask them where they rate their pain. And then for older children, you can just get a piece of paper and you can draw a line across it and ask them to mark where they feel it like they are on the pain. That gives them some kind of visual to look at. And this being no pain, this over here, the worst pain you can imagine, mark on this line where you feel you are. Or a lot of them commonly use that with 0 being no pain, 10 the worst you can imagine, what's your rating? So that's a numerical rating scale. So once we've determined that this person has acute pain, then we need to treat it. And we, unfortunately, our medication has not changed in forever. We have non-steroidals, and we've got some opioids. So that's the kind of pharmacological stuff. But it's also important to draw from other categories as well. So behavioral interventions such as relaxation, deep breathing. And whenever we're able to have camp, actually, we hopefully will next year, but our psychology team comes out and we work on some of these things with the children and the teenagers to try to teach them how to manage pain. Psychological interventions important. So distractions. I know a lot of us sometimes we're like, oh my, they're on their phone and they can't be in pain. Well, that could also be a coping mechanism for them as well to distract themselves from the pain. I know, like for me personally, I have headaches at work. I don't think about it. As soon as I go sit in my car after work to go home, my head's hurting because I'm no longer distracted by all of you and all work. Physical hydration is super important. So we're really trying to push more water and less of the like Gatorade, something like that, to have a lot of salt in them, because if you give them a high sodium load, could you cause some dehydration? So we're really trying to push water. And of course, in heat, you get vasodilation instead of the cold that causes vasoconstriction. And kind of light massage, deep tissue massage can actually start hurting them, but sometimes you'll often find it like to be rubbed on the area where they're having pain. So most pain, 90%, treated at home. I think a lot of people, they think, oh my God, these people are in the hospital all the time or in the clinic or ED all the time, but the majority of pain is treated at home actually. And so you can imagine the impact that may have on school, work, and social interaction. But anyhow, we recommend to drink a lot of water at home, and then to alternate acetaminophen with or without an opioid with ibuprofen. So again, because the acetaminophen opioid, they're targeting, telling the brain not to have pain. The non-steroidal is targeting that pain locally, all the inflammation those patients can get. So that's why we recommend alternating those medicines. And then, as y'all know, codeine was for children under 12. It's not approved. So we've switched from codeine to using more hydrocodone. Hydrocodone gets converted to Dilaudid, basically, because it gets converted to hydromorphone inside your body after you take it. Moderate pain, kind of more that maybe 4, 5, 6 level of pain, kind of middle of the pain scales there. And that's usually in the ED or in an office somewhere where they require something IV. And so by that point, usually they're getting some IV ketorolac. We recommend that as a non-steroidal choice unless there's any contraindication. And then an IV or an oral opioid. Now, next slide. And then as far as whole fluid thing, we used to always push a lot of fluids on these patients, but now that can be a contributor to acute chest, which we know is the biggest cause of mortality in kids. And so there's been a big pushback. In 2014, the NIH published some new sickle cell guidelines and said, do not overhydrate these kids who come in with a pain crises, because then that's a setup for acute chest. So unless they're dehydrated, they shouldn't be getting fluid boluses anymore, and to keep them euvolemic. Okay, and that's going to be a kind of that y'all can help change that mindset in the ER. They allow them to get fluid boluses. So some fluids if they need it, and this should be goals to get pain medication to them quickly, so you can try to jump on their pain and maybe prevent hospitalizations. And again, ketorolac, and then an opioid, either IV or oral. As far as the lab work that we usually we recommend, of course, check their vital signs, make sure there's no fever, make sure their sats are normal, blood pressure's okay. And then we recommend the minimum workup I recommend usually is a CBC and a retic to see if they're baseline or not. You might see an elevated white count because of the inflammation with a pain crisis. They could be a little more anemic, a little higher retic because of increased hemolysis with their pain crisis. And then I usually get a creatinine, either BNP or RFP, if you should be given some ketorolac. So I want to make sure that creatinine's fine. And then your other labs is necessary. So, so let's say you got in their pain medication, reassess 30 minutes later. And if they're, then you need to give them either another dose of IV medicine if their pain's not controlled. We usually recommend like 50% of the dose for the repeat dose, or if their pain's starting to get better, give them an oral opioid. And then if they're, and then you have to decide, am I going to admit this patient or can they go home? And we recommend after that second dose, don't just give it to them and they say, oh, I feel better, I'm going home. Because once that pain medication wears off, they're going to be back in your ER 3 hours later, 4 hours later, and then you're going to say, oh, they just want medication again. They're drug seeking. That's how these patients can become mislabeled as drug seekers, because we don't do a good job of seeing. Yes, they might feel better after some pain medication, but once that medication's half-life is decreasing, then they come back in again. So that's what we recommend. I know the EDs are busy, but try to, after that second dose, try to watch them for 3 hours or so in the ED or in our office to make sure that they don't have any rebound pain, that their pain is adequately going to be controlled. So, IV pain medication, 30 minutes, an hour later, more IV if needed versus oral. They do the oral trial, watch them for, try to watch them for 3 hours or so, make sure there's no rebound pain, then they can go home. If they're able to go home, we recommend taking that ibuprofen and opioid at home on a schedule for the next 24 or 48 hours, so then go to as needed. And then, of course, if they're not better, they get admitted. So when they come into the hospital, most of these patients, they know what they normally do. They know their bodies, especially the older ones, and they know if they need to go, if they want to be on, scheduled narcotic versus a continuous infusion with the PCA. And the PCA is the button part, the patient-controlled analgesia part. At baseline, though, we usually keep that ketorolac going unless there's some contraindication. And y'all know about the 5-day max per month because of the concerns for nephrotoxicity, also GI toxicity too, but nephrotoxicity. So then we pick our medication that we're going to give them, and then let's say they're either they've had scheduled around the clock opioid or continuous infusion PCA. Let's say they start getting better, they need to go home. You don't just cold turkey send them home. We need to, depending on how long they have been on the narcotic, we need to wean off of that so we don't have any cold turkey stop it and either one have rebound pain crisis or have them have withdrawal, depending on how long they've been on it. But if they've been out for a relatively short, less than 5 days, 7 days or so, you can wean it pretty quickly by about even 50% every 24 hours. But they've been out for longer than 5 or 7 days, wean more like about 20% a day. And then whenever you get your opioid IV down to a level that be kind of equivalent to an oral equivalent opioid, you can switch them over then, and then watch them for another half day or so. And if their pain's controlled, then go home. Again, that scheduled usually ibuprofen. At that point, we have switched their IV ketorolac to ibuprofen and a scheduled oral opioid for the next 24 hours or so. All right. As far as these medications are not without side effects, and so we see lots of some nausea and vomiting. So we would do ondansetron, which is non-sedating, like the older Phenergan. We used to sometimes use it, which some places still give that, but try to stay away from anything that can cause more sedation because you're already getting sedating pain medication, and we don't want them to risk not breathing well, acute chest, atelectasis, and then acute chest. So ondansetron is what we typically do. All these medicines can cause itching. Hydromorphone supposedly causes less pruritus than morphine, but so that would be one advantage for hydromorphone. But regardless, if they have itching, they might need something for the itching. And again, we don't want to give anything that can be too sedating. So definitely no IV Benadryl. Okay, and that's in the 2014 guidelines. That's a no-no because one, it has a faster onset of action, more sedation, and you're giving an opioid, you have a patient not breathing very well. So so it should be oral, and then usually we try to do kind of a lower dose because of the sedative properties, but hopefully it would have the antipruritic effect. So diphenhydramine or hydroxyzine PO. And then some centers use low dose naloxone because so you can block some mu receptors, but not totally all the mu receptors, so that you can to relieve the pruritus. As you know, these medicines are constipating, so they should all be on laxative or stool softener. We know that they're set up for acute chest. And so if they're not breathing well, or if they from the pain medication, or if they're splinting from having pain. So we work really hard to try to prevent acute chest. And this is a very small study. Why we do the incidence spirometry is 10 inhalations. The study was done 10 inhalations every 2 hours while awake for patients that came in with back pain, with sickle cell or chest pain, and it was shown to significantly reduce acute chest. That's why we do the incidence spirometry. And then albuterol with PEP. That is in like no guidelines or anything. That's just something that when I was in fellowship, we started to do. And a lot of centers do the albuterol because a lot of these kids with sickle cell and adults, they are prone, they have more reactive airway disease than the general population. And that could be a setup for acute chest. And so just in people do albuterol every 4 hours. And then here, whenever I got here, well, I was in fellowship too, but we did it with PEP, positive expiratory pressure. And we think that helps to significantly also further decrease their acute chest. Again, there's no data for that. That's just kind of anecdotal. Respiratory therapists don't, they get irritated because there's no data, but we, like whenever Dr. Shilpa got here, she was like, you don't have hardly any acute chest here. And we think it's the PEP, maybe albuterol, we don't know. This is Shannon, the pharmacist, and we kept saying we should need to write this up. That was a long time ago, we never did. Sorry, this is Dr. Camps again, sorry. Okay, all right. I'm in, sure. Can you ask Gabby to go to bleeding? Yeah, can she go to the bleeding room? Sorry.
Where's the bleeding room?
She's hearing you over that.
Sorry. Where you were this morning? Sorry. Fever is not uncommon during a pain crisis. This is the inflammatory response that they can have. And so if they do develop fever, it may just be due to the pain crisis, but if it's 101 or higher, we do recommend you go ahead and do that workup. And so this is also per those 2014 NIH guidelines, but the minimum workup we recommend is CBC and a retic. And the reason for that retic is that you may pick up, if they have like some viral suppression, aplastic crisis, you may pick up an inappropriate low retic for their degree of anemia, because maybe some virus triggered this pain crisis. And then blood culture and a dose of ceftriaxone. If there's any concerns for acute chest, of course, rapid chest X-ray, and then you need to start thinking too, could this be, is this really osteomyelitis or something, or a septic joint I'm dealing with, and not just a simple pain crisis? And so to consider, especially if there's focality, checking the SED rate and they and a CRP. There is a little bit of data in sickle cell that at baseline they can have an elevated SED rate, but it should go up more with with osteomyelitis, and as well as the CRP should also go up more with osteomyelitis than just with a simple pain crisis. And then just some reminders, we don't give them any non-steroidals if they've got any contraindications like any gastritis or kidney issues, because many of our patients have sickle cell nephropathy, so that's why they don't get any the non-steroidals. If they had any liver disease, no acetaminophen. And then people I think don't really use Demerol anymore, thankfully, but that was a very good pain medication, but I think patients get a rush from it. So a lot of older patients have had this medication before and like it. But if you give repeated doses of Demerol, which is meperidine, the metabolite normeperidine can cause some CNS excitability, and these patients who are prone to strokes already, they can start seizing on your, after they've been in the hospital getting Demerol for 3 or 4 days in a row, then you can have a seizing patient. So no meperidine unless they have a true allergy to the other opioids. And then a lot of times too, when these patients go into a ED for a pain crisis, oxygen gets put on them empirically, even if their sats are normal. But we don't recommend that, because if you give oxygen unnecessarily to somebody with sickle cell, it's been shown, this was a very small study, a few patients, they have about a week later, their hemoglobin drops. Their body's like, hey, I'm getting all this oxygen. I don't need to make my own red cells. I don't have as much drive to make my red cells. So a week later, you know, their retics going to go down, their hemoglobin's going to drop because they have less drive to make their own red cells. So don't give oxygen unless they are hypoxic. So the goal, 95% or higher. And then, of course, avoid the fluid overload because of the risk of acute chest. If you do have a patient who is over sedated, just give them a tiny dose of Narcan, because if you give them the big dose, the regular dose, you're going to unbind all those bound mu receptors, and you're going to have a wildly unhappy patient screaming in pain. So you can just a small dose try to take away that the respiratory depression that they had, and then lower your dose of narcotic. That would be preferable rather than undoing everything you've already done. And then remember, a blood transfusion is not treatment for a pain crisis. Okay, so even you expect they are going to get more anemic during a pain crisis, but a transfusion is not indicated. All right, so now say you have a patient with 14-year-old with sickle cell who is admitted with a typical pain crisis in her low back, and day 3 of the hospitalization develops fever, tachypnea, SATs 92%, having pain. He's on scheduled morphine and ketorolac, and on 1 1/4 maintenance fluids. He's on a bowel regimen, so he's not constipated as a reason for the pain. Doesn't have any dysuria. And on exam, you hear some rails in both bases, a little bit of agophony on the right, and his back is tender. So what are you concerned about? Acute chest, ding, ding, yes, acute chest syndrome. So we work super hard to try to prevent this, but it can still happen. And so some patients with acute chest, they can present with fever or respiratory symptoms. But reportedly in some older reviews, about a quarter of the patients actually had no fever with acute chest, and about a third of them had a normal lung exam. But it's pretty common, about a third of patients will have at least one episode, and it is a leading cause of death, which is why we work so hard to try to prevent it. As far as the reasons for it, multifactorial. It could be because we give them too much fluid when they come in, so that child's on 1 1/4 maintenance. That should be a no-no. They should be euvolene. So they should not get fluids more than 1 time maintenance when they come into the hospital. Okay, and then you need to decrease their fluids as their PO intake is increasing. It could be that so they were on 1 1/4 maintenance. Maybe they had a pulmonary fat embolus. So it's not uncommon for a teenager, they come in with some long bone pain and some fat inside your bone marrow. And so some of that, from where that infarcted marrow was, some of that fat could get out into the bloodstream, the veins on the bone, and go and shower the lungs with these little pulmonary fat emboli. So that could be, so that's why they come in with pain crisis, 3 or 4 days later develop acute chest. That could be a reason as well. It could also be due to atelectasis, either that we contribute to by over sedating them from pain medication, or by not controlling their pain well enough and they're not breathing well and they're splinting and have atelectasis. So you make your pain medication just right. Could be due to infection. And this is again some older data, but the most common infectious organisms, people would typically think it should be the encapsulated bacteria, right? Because your spleens aren't working well, but it's actually going to be the atypicals. And so that's why we always do the covered with azithromycin or whatever atypical coverage you want to use. But chlamydia mycoplasma were the top 1 and 2 infectious organisms that were seen in this study in California again years ago. And strep pneumo stuff was further down the line. And it could just be infarction. So maybe that you have these vessels in your lungs, and so maybe the alveoli aren't getting what they need, and they are infarcted. So we try to be non-invasive, with acute chest. So because our reasons are so multifactorial, our treatment is multifactorial as well. So antibiotics, so they'll cover the typicals and the atypicals, the pain management, so make it just right and avoid fluid overload. And then you want to maximize their pulmonary toilet, so incidence spirometry, oxygen if they need it to keep their SAT 95% or higher. You'll see us transfer some of these patients to the PICU for BiPAP. Rarely do you have to be intubated. I've only seen about 2 patients intubated, and I've been here for 20 years. So we try super hard to, again, prevent, but then to be more aggressive with our treatment when it does develop. And blood is the other kind of mainstay. And so this is also per the last NIH guidelines. that if their baseline hemoglobin is less than 9, so that implies that's probably that more severe, that SS or sickle beta 0 thalassemia type, their hemoglobin's a gram below baseline and they're symptomatic, give them some blood. And the reason for all those caveats is because if you give, 10 cc's per kilo of blood, it's going to raise your hemoglobin by a couple of 2 or 3 grams per deciliter. So if, let's say their hemoglobin was 9, and you gave them, 10 cc's of blood, and you got them hemoglobin to 12, then you can have a hyperviscous state, and then you're going to have poor blood flow and sludging, and then more problems. So you don't want to over transfuse these patients. That's why all those caveats are there about the hemoglobin level. If their hemoglobin is too high, though, like if it's an SC maybe, or a sickle beta plus thalassemia patient, or a patient with SS who's got really, really severe acute chest, then those patients need an exchange transfusion. So where you're, taking off blood, but putting back in blood. And then as far as the whole steroid thing, steroids actually, they were studied for acute chest and they did work, but many of these patients, after they went home from the hospital, came back in with a rebound pain crisis. So steroids, these patients live in this kind of revved up inflammatory state. You give them steroids, you alter that inflammatory state. If you just did a 3 or 5 day burst, this is for asthma also, and you cold turkey stop it, many of them are going to come back in have a rebound pain crisis. So if you do have to give steroids, then you need to make sure you wean them off over about a week, or 5 or 7 days or so for asthma. All right, what does this patient have? What do you see on this smear? There's a sickle cell. Yep. And then there's some nucleated red cells. So the red cells that have the black in the middle, purple in the middle, those, and you don't, this is a peripheral blood smear. So you don't only see nucleated red cells in the periphery. So that tells you have a really active marrow that's been an immature cell. So not uncommon for sickle cell. And then you also see some purple dots in the red cells. What are those? Yes, Alpha-Jolly bodies. So what's this patient? Why do you see those? Yep. So splenic dysfunction starts at a very young age. So because your spleen is kind of like a filter, helps you get rid of these abnormal red cells. So if you had a functioning spleen, spleen would say, hey, I recognize you, Alpha-Jolly body is abnormal. I'm going to take a bite out of you and get rid of you. But because you don't have a functioning spleen, you see those abnormal red cells in circulation. So if you see that on the, the text, they'll report that on the smears of these patients. So that you would assume they have splenic dysfunction if you see a Howard-Jolly body. Starts at a very young age. And this, the spleen is incredibly vascular. So you have all this little infarcts basically, and it just starts to kind of scar up and shrivels up and not working very well. And by 5 years of age, 94% of patients with SS have functional asplenia. So they're profoundly at risk for infection from encapsulated organisms. The dysfunction starts a little bit later age for SC and sickle beta thalassemia, but it can happen. So again, this is the cover for those guidelines, which you should all read at some point. If it's about 100 pages, it's a quick read. Acute and chronic pediatric and adult sickle cell. But anyhow, per these guidelines, if you have fever and sickle cell, you need a minimum workup, CBC, retic, blood culture, dose of ceftriaxone. And if their temperature is 103.1 or they're ill appearing, they get admitted. So I'm going to skip through the infant stuff and sickle cell, but because most of our patients that the infant workup, y'all would do your regular infant workup like you would do. But for patients that are older than 2 months of age who have fever, again, do that workup and get the ceftriaxone into them promptly. And the reason for this is that if you worry about not just strep pneumo, but also all the encapsulated bacteria, H. flu, salmonella, but strep pneumo, if you have that you can get very sick very fast and die. So they got a very high mortality rate. So that's the reason for the prompt antibiotics in the workup. And that's the reason too that we teach these parents and these children, if you have fever, do not take Tylenol or ibuprofen, stay at home. You got to go get checked out and go expect to have the blood work done, blood culture done, Rocephin given, no matter how well appearing you may be or ear infection, whatever that does not mean that you do not do your whole workup. So as far as admission or not, so we know we're going to admit if they got really high fever, you're going to admit them, or if they're ill appearing. But the guidelines don't state out what didn't write what ill appearance was. We just took some information from some older studies, and I think they all have this in the ED about recommended criteria to admit for. It's like if they're white count's too high or too low, because that can go along with sepsis. If of course, if they're ill appearing, if they have something else going on, like if they have acute chest or pain, you would admit those patients as well. Or they have a cephalosporin allergy, because there's no 24-hour long-lasting antibody that you could give. But if they, so their temperature is not that high and they're not ill appearing, if they're stable after that dose of ceftriaxone, if they're updated with their vaccines, if they're compliant, reliable, social situation, then they can go home from the ED. And the guidelines say that you can consider a course of oral antibiotics. And so we'll often do like a 3-day course of ceftonir. That probably helps us feel better, maybe nothing for the patient, but we feel like they're kind of covered. And then they should be followed up the next day, at least with a phone call. And this, I need to add to this slide. So this is, because we actually have 3 more cases. So 11 cases is IPD, invasive pneumococcal disease since 2000. And the reason we picked 2000, that's the year that Prevnar was introduced as a vaccine. And so we saw a decrease in pneumococcus after Prevnar 7 was introduced. In 2010, Prevnar 13 was introduced, and we again saw kind of a decline in pneumococcus after that. And then I haven't added these next patients in here because we've had in 2019, 2020, 3 more patients with strep pneumo. And so it's been about like, and the cases that we're seeing have serotypes not covered by Prevnar or by Pneumovax. So it's like we get this new vaccine, we're all good for a while, and then some serotypes that they start to sneak, they become more prevalent that are not covered by any vaccines. So we have no new vaccine on the horizon. I think we've all, with the mask right now, we're all kind of protected. We've not seen any cases this year, but and it's not a lot of cases, but with 30% mortality from our patients that we have here. So fever, do not stay at home, do not take Tylenol, Motrin, go get checked out and do the minimum workup, more stuff if you need to, get that dose of antibiotic in them. All right. So now let's say you're all in the ED and a 15-month-old comes in with 1-day history of fussiness and due to presumed abdominal pains, taking longer naps than usual, took some pain medicine at home, helped temporarily, but worse again, no fever or anything. On exam, he's drowsy, he's pale, he's a hair, he has a 3/6 systolic ejection murmur. Normally you just hear about 2/6 in the office, but he's 3/6 in the, so a little louder murmur. He has a tender left upper quadrant mass. And presumably that mass is his spleen. Yes, the spleen. So the spleen, so again, we worry about spleen sequestration. That's something, an acute problem these patients can have. And with the patient with the more severe type, usually by the time they're 5, they auto-infarct their spleen. So if they get sequestration issues, going to be in the toddlers. But remember, your patients with the SC and sickle beta plus who have the less severe type of sickle cell, they can sequester any age, teenagers, adult, any age. And so if a patient comes in with kind of acute onset left side pain, pale, weak, tired, you need to think about that. And they're kind of remember the rule of 2s. So their hemoglobin will usually drop 2 grams below baseline, and their spleen is usually 2 centimeters bigger than baseline. And happens in about a third of our patients. About a third of our patients have their spleen removed actually, because there's a 50% chance it could happen again. And this can obviously be fatal. We've seen some children coming in with, hemoglobins in like 1.5, 2, who are incredibly, lethargic, and if they're not near close to a center to get blood quickly, they could die. So they need to get blood. That's the treatment. And if you have time, you should do the antigen match blood, but sometimes you don't because it's an emergency situation. You just give them, and we'll get the blood in a little bit, but give them CE-Cal negative. But anyhow, with the spleen, you don't usually give your typical like 10 cc's per kilo, because that could raise you by 3 grams per deciliter. And so let's say you have a child whose baseline hemoglobin is 7. So they come in with a hemoglobin of 2. So you got 5 grams of hemoglobin in that spleen. You give them 10 cc's per kilo, they're going to go up to let's say to 5. And then once you start getting that normal blood, the trapped blood inside the spleen is going to get released from all those sinusoids. They're going to have an auto transfusions. As their spleen gets smaller, their hemoglobin's going to go up again from their own auto transfusion. So you don't want it to overshoot and make them hyperviscous. So usually we'll just give small amounts of blood. So you can ask the blood bank to split your unit into aliquots. And so usually we may get like 5, 7.5 cc's per kilo. give them the blood, check their hemoglobin spleen an hour later, give them more blood if you need to get them to about a level of 8 or so, because you don't want to overshoot, because as that spleen's going to get smaller, you don't want them to become hyperviscous. And again, if they have a severe episode like a hemoglobin 1 or 2, that spleen needs to come out. The 50% chance it's going to happen again. Or they're kind of recurrent moderate episodes, where I recommend that spleen be removed. All right, this is the last problem, stroke. And we've seen many strokes recently, but not for sickle cell. Well, not thankfully for anybody, but for sickle cell. So historically, about 11% of kids around 6 years of age had a stroke, large vessel infarctive stroke, just like an older person would. And but we don't see that much anymore, because now we do TCDs or transcranial Doppler ultrasounds to see who's at risk. So here across the country, we've seen a decline in our strokes since we started doing TCDs back around 2000 or so. But it can still happen, because we have some patients who comply with their TCDs, or we have some patients who've had abnormal TCDs and the parents refuse transfusions, which would be the treatment if you have an abnormal TCD. So they come in with a stroke. What are you going to do? I think that is part of that BAT. I guess we'll hear about this on Friday at Grand Rounds. But on the BAT protocol, it says for sickle cell, you're supposed to call Heme. Don't do the whole BAT thing. Okay. So call Heme. And then we would recommend, if you can get an MRA quickly, because this would be a large artery that's affected, then get that. But if not, get a head CT, because you need to make sure there's no bleed. Most of the kids have an infarctus stroke. Very rarely would they have a hemorrhagic stroke, but you want to make sure there's no blood. And even if you can't get your MRA to prove occlusion in your MRI, because your MRI diffusion picks up the stroke early on, whereas a CT scan could look normal in the beginning because you haven't had a chance for that fluid to move out, shift out of the cells. You do your in-exchange transfusions. These kids get a double lumen femoral line, go to the PICU, and then we call the Red Cross, and they come over with their pheresis machine, and they do an exchange transfusion. So they were going to, from one lumen, they take out patient's blood, it goes through the machine, separates out the red cells from the platelets from the plasma. Platelets and plasma get reinfused back in, and then some normal blood gets infused. So our goal is about a 1.5 times blood volume exchange to get that sickle percent from, we assume it's about 100 down to about 30 is our goal. And for the blood, so it can, y'all, you order this antigen matched blood for people with sickle cell. That can take several hours to days to find antigen matched blood. So for the exchanges, you don't have time, you don't have that time. So they get big C, big E, and Kel negative. And I'm going to skip on over here to the transfusion part. So all your blood should be matched up for your blood type, like your A, B, or O, RH type. But there are other antigens on the red cells that if you get exposed to them, then you could make an antibody, and that could then result in a reaction, an antibody transfusion, platelet transfusion reaction down the road. So a lot of people, of our sickle cell patients, not all of them are African Americans. And a lot of our donors for blood in the United States are of white Northern European ancestry and have different antigens than many of our sickle cell patients do. And so that's the reason for the antigen matching, because a lot of Northern Europeans are big C, big E, and Kel positive. A lot of African Americans are not. And so if you just gave regular, like, let's say they're A positive blood, there's about a 25% chance that child's going to get exposed to a big C, big E, or Kel, make an antibody. You may not know about it at the time. Let's say they don't need blood again for another 10 years. They come in with acute chest. 10 years later, you give them some more blood, just A positive matched blood. And then about 10 days later, they come in, they go home with their acute chest, come back in the ER about 7 days later with horrible back pain, dark urine, icterus, and they're more anemic because they've got a delayed hemolytic transfusion reaction. The antibody had become quiescent, and you re-expose them. So our goal is to prevent antibodies. But again, because we can't, it can take a while to find an antigen matched blood. If you have an emergency, like in a stroke or a severe splenic sequestration, the blood banks keep big C, big E, and Kel negative blood on the shelves for our patients with sickle cell. So in emergency, use that. Rarely have used O negative. Had to use that one time for a spleen. The hemoglobin was at 1. Came to the ER. They got O negative blood. So that's the blood. So I think this is actually the last. So for blood, we talked about this earlier. It's not used for pain crises. but it is used for stroke, spleen, and acute chest. Sometimes the aplastic crisis when they're really, really anemic. And that's what this slide here was talking about. So use it responsibly. And I know that was kind of a whirlwind. I appreciate your grace today. And they're leaving, and so there must be a problem. Do you have any questions?
Yeah,
Okay.
thank you so much.
Okay, guys.
Yeah,
Yeah.
Is that just because like the vital signs can be more anemic, or
It shouldn't be. They may not have, like with a pain crisis, they may not have an all, like you may not see any vital sign instability, except sometimes or changes. Except sometimes the elevated temperature, like 99, 100 for the inflammation, but they may, I don't know what you may not see other objective things like your higher blood pressure or heart rate. Some patients do, and yeah, I don't know why that is actually. Yeah, don't use that as a reason, but sometimes you do want a little temperature elevation. Okay.